My name is Lisa Jerome. I'm the Vice President of Marketing and Communications and Community Giving at Toronto General and Western Hospital Foundation. And it's a real pleasure to be here today. This is our 12th year of offering our behind-the-scenes lectures. And this is really an opportunity that we feel it's important to you as our very loyal and generous donors to provide you access to the latest and greatest research updates and hear from some of the amazing experts that we have right here in Toronto Western and at Toronto General. And this is really an opportunity for you to engage with this information, and we like to provide the opportunity for you to also ask questions as well. And today, I think, is a really great day. We're featuring brain disorders, and we have two superstars here with Dr. Timo Krings and Dr. Mojgan Hodaie, and they have some brief presentations for you, and then we're also going to be hearing from a patient who has had a great experience here as well, and she wants to share her story with all of you today. So I hope you have all received your report on your support newsletter in the mail that is featuring Dr. Krings and Dr. Hodaie, and if you don't have it, make sure you pick one up on the way out, because it will give you a little more information about them as well. But first, I'm going to start by introducing Dr. Krings. And Dr. Krings is the David Braley and Nancy Gordon Chairholder in Interventional Neuroradiology. He heads up the Division of Neuroradiology and is the Site Chief of Medical Imaging at Toronto Western Hospital. He's a Professor of Radiology and Surgery at University of Toronto, and he performs pediatric and adult endovascular procedures. He is an expert in complex brain and spinal vascular malformations. And his research focus is around the prediction, development, and effectiveness of therapies for bleeding in the brain from these vascular malformations. And he has many distinguished grants and awards, and I'll just name a few of them here. He's received the Scientific Award of the European Society of Neuroradiology. He has the Lucien Appel Prize. He has the Founders Award in Interventional Neuroradiology of the European Society of Neuroradiology, and has the Edward Lansdowne Award for Outstanding Teaching at University of Toronto. So I would like to introduce Timo Krings to present to us now. Thank you.
Thank you very much for this very kind introduction, and most importantly, thank you to all of you who are here as you are supporting our research. And today in my talk, I will talk a little bit about the research that we have been doing and how it translates directly to patient care. And it is with great pride that we can say that some of the research that we are doing have indeed transformed the lives of thousands of Canadians and millions of people worldwide, because we have changed the standard of care in acute stroke treatment. So I will talk about stroke management and how it is done nowadays. If you are expecting a very sophisticated talk, I'll have to disappoint you. It will be like a talk about plumbing and about pipes, and about a couple of pipes that are actually very important. And these are the pipes that are the blood vessels that go towards the brain. And you can have problems with these blood vessels. You can either have a clogged pipe or you can have a burst pipe. A clogged pipe means that the blood vessel that goes to the brain is occluded, and therefore the blood, and thus the oxygen and all the nutrients, can no longer go towards the brain. This is called an ischemic stroke. And when there is no longer oxygen going to the brain cells die, and they die at a very rapid rate. They die at 2 million neurons per minute. On the other side, you have the burst pipe. This is the hemorrhagic stroke, where blood exits out of the blood vessel and enters into the brain. Patients often have a catastrophic headache and will need immediate fixing of this burst pipe. I will mainly focus on the ischemic stroke today, and we'll start off with a couple of numbers. Stroke is the third leading cause of death in Canada. 14,000 Canadians each year die from a stroke. That's 6% of all deaths. And we have one stroke every 10 minutes across Canada, 50,000 strokes each year. And there's also a significant healthcare burden, economic burden. In fact, stroke cost an estimated $3.6 billion a year in hospital cost, lost wages and decreased productivity. But these are just the numbers. What is way more important is the impact on the patient. Patients are no longer able to speak after a stroke. They are paralyzed, they can't move one side of their body, and they can't walk any longer. And these are significant changes, obviously, in the life of these patients who do survive. Now, what do we do with blocked pipes? We can do either Drano or a snare. And the same actually holds true for the brain pipes. You can either give a drug into your bloodstream that will dissolve the clot. This is called TPA, and this has been the standard of care for the last 20 to 30 years. Or you put a snare into the blood vessels and try to get the blood clot out. Now, how do these two methods compare with each other? In order to read this diagram, I will tell you what MRS means modified Rankin scale, and this is the way that we look at our patients after they had a disease. A modified Rankin scale of 0 to 2 means that the patient has independent living. Modified Rankin 3 to 5 means that he is dependent on someone. Modified Rankin of 6 means death. If you give the Drano, the TPA, the clot-busting drug, 40% of patients have an independent living. What about the snare? What about these techniques where we try to get the clot out? This is data that is approximately 10 years old. And in all of these studies, you can see that with these new types of treatments, we didn't really get too much better. What is the reason? Well, the snares that we were using looked something like this. Actually, these are the true pictures of some of the devices that we put into people's brain to try to get the clot out. And they look like a chimney sweeper tool or something that you actually open your bottle of wine with, but not take out a clot. So the results really were not this good. However, then the game changer came. And the game changer is a way more gentle way of getting the clot out of the pipe. First, we put in a small wire through the clot. Then gently over this wire as a rail, we put a so-called microcatheter, i.e. a tube that can pass through the clot. Then the rail is removed, the microguide wire is removed, and now within the blood vessel, we have an open tube. Through this small tube, we can push a collapsible stent. And this stent is a metal strut that can be now unsheathed, i.e. we are removing the microcatheter and thus the stent is grabbing the clot. The grabbed clot will then be pulled out of the blood vessels into a so-called guiding catheter that I have parked in the carotid artery, thus restoring the blood flow. And it sounds like science fiction, but it actually does work very well, and not only in this movie, but in real life. These are the data that we were able to present, and these are data from multiple different studies. This is the Canadian trial that we were heavily involved in. There's a worldwide trial, and there's a Dutch trial right here, and there's in addition an Australian trial. And if you look at the positive outcome in these types of trials as compared to the standard of care, we are doubling the like a good outcome. We are doubling the independent living following a stroke thrombectomy using these types of devices. And now we'll have to go again through some numbers. The number that we are always looking at when we are evaluating how good the effect of a certain treatment is the so-called number needed to treat. The number needed to treat means how many patients do I have to treat to get one patient better. What is the number needed to treat of the previous standard of care, the so-called intravenous therapy of stroke? The number needed to treat is 9. You need to treat 9 patients to get one better. What is the number needed to treat for myocardial infarction? i.e., if you have a heart disease and you want to put in a stent to get actually your heart again running. The number needed to treat for myocardial infarction is 8. i.e., you need to treat 8 patients to get one better. Antibiotics for mastoidal infection, i.e., if you have an ear infection, how many patients do you have to treat with antibiotics to get one better? Any idea?
6.
Very close, 7. Okay. What is the number needed to treat now for stroke thrombectomy? First, why in the Netherlands? Well, the first study on it was done in the Netherlands, and they found out that their number needed to treat is 7. What about the worldwide studies? In the worldwide studies with this stroke thrombectomy, they found that the number needed to treat was 4. What about the Canadian trial? The Canadian trial demonstrated also number needed to treat 4. Then there was an Australian trial that demonstrated number needed to treat is 3. And then we looked at our own data here at the Toronto Western Hospital. And for us, the number needed to treat is actually 1.7. So this is where we are. Thank you. But stroke treatment is more than numbers. Stroke treatment has really changed the way that we are dealing with our patients, and has changed the way that the outcome of patients are. This is one story of a very happy patient who was treated and had no sequelae following the treatment. We have examples of a concert pianist who was unable to move her hands, who would have lost her job, obviously, and she's now back, and she's actually an Emmy recording artist. We had one patient, a 93-year-old patient, there was called at 4 o'clock in the morning, and I said, 4 o'clock in the morning was really like a little bit early or late, depending. And I said, really, 93-year-old patient? Yeah, the stroke neurologist said she got the stroke while dancing. And I looked at the clock and I said, but it's 4 o'clock and brain cells die with 2 million cells per minute. So presumably she danced 9 hours ago. No, Timo, she danced at midnight and at 1 o'clock she had the stroke. I said, well, she has a better lifestyle than me, so I better should go into the hospital right now. And she's back. She's back and lives a fulfilled life. I had a very big, tall guy who was working in construction, and he was unable to move his hand. And the type of treatment that we are doing is done under conscious sedation, so the patients are awake while we are taking out the clot. And I was standing next to his bed while I'm doing the procedure. And the procedure has a very short moment that is a little bit painful. This is the moment where we pull out the clot. And he was groaning and moaning. And the next thing I felt was his punching me here. And I was actually quite happy because previously he was unable to move his hand. So it does have an impact, of course, on my family life. Not the punching, but My youngest daughter, she's 6 years old, she likes to actually hide my cell phone when I'm on call, because I can be called any moment, and typically during bedtime stories. That's obviously a very classical one. Now, acute ischemic stroke is a matter of seconds. As I told you, for each minute that we are not opening the blood vessel, 2 million neurons are dying. Or, to put it differently, for each hour that we are not opening the blood vessel, the brain loses as many neurons as it would lose in 3.6 years of aging. And this is why we'll have to be fast. And this is why acute ischemic stroke is what I like to call a team sport. We are not like the single person who are single-handedly doing everything. We need to work together as a team. We need to, first of all, educate the patients. Patients who do not know that they have a stroke will not call 911. They need to know that they have a stroke. So we have to educate them that, and it's a stroke, it's treatment, you have to act fast. FAST is an acronym for F. Is your face uneven? Is one arm hanging down? Is your speech slurred? Then it's time to call 911. The next part of the chain of stroke treatment is that we have to look at the EMS services. They should not go to Mount St. elsewhere with a stroke patient, but immediately to a stroke center. And so we have to map out the province. And while mapping out the province, we were able to demonstrate that there are certain areas, North Bay, for example, Sudbury, where we need EVT centers. No patient will be able to get fast enough to here. And we are therefore right now educating a neuroradiologist from Sudbury and teaching him how to perform stroke treatment. We need imaging. Imaging has to demonstrate, or can demonstrate, where exactly the clot is sitting, which pipe is clogged, and therefore where to go. And then we'll have to work fast in the angio suite. So here is our angio suite, and the small threads and that we are able to get in, and with these X-ray machines we are able to visualize where we are in the brain. We are going all the way from the groin up, and our fastest stroke treatment was actually done in 7 minutes from groin puncture to opening the blood vessels. And this is one of the examples. Here, this blood vessel is burst or blocked at this level. We've tried once. This was at 3:34 in the morning. This didn't work with thromboaspiration. We tried different techniques, and finally, we were sandwiching the clot between two of those stent retrievers that we are visualizing here, and this finally opened the blood vessel completely, and the patient went home and is back to baseline. What comes next? The next types of studies that we are planning are epidemiological studies where we are looking at large data. What if a patient comes after 6 hours? What if a patient comes too late? Is there such thing as a too old patient? Does the 93-year-old patient really warrant treatment? In my opinion, they do, of course. What about those strokes that have an occluded vessel but the patients are actually doing clinically well? What about those patients that are too far away? How can we best get these patients to a center that is actually performing this treatment? Do we have to go for quantity or for quality? i.e., should all patients go to one single center that is extremely good at it? Or should we have many, many different centers all over the place that may not be as good? Remember the number needed to treat in the Dutch trial, 7 versus 1.4. Where is the sweet spot? So this actually is going into even health economic data and research that we'll have to look for. We want to get faster and more gentle, so we are working on device and equipment development here, and we want to make sure that there is a good care for all Ontarians and all Canadians, and this is why we have to work in education and health services research. And of course, I did not tell you anything about the burst pipe. This is for our next behind-the-scenes lecture, so put it into your calendars. What do we do with the burst pipe? We'll talk about this later. And just to remind you, stroke can hit all ages. The oldest patient I treated was 104 years, and this is the youngest patient, or one of the youngest. She was 4 years old, and she had a stroke and is back on the road again and is actually doing very well. Thank you very much for your attention.
Wow, thank you very much, Dr. Krings. That was absolutely fascinating. And I think we'll be fascinated by our next speaker as well. And I'm going to introduce Dr. Mojgan Hodaie. She is a neurosurgeon and surgical co-director of the Joey and Toby Tannenbaum Family Gamma Knife Center here. Her field of clinical expertise and her research interests are in neuromodulation for the treatment of movement disorders and pain, surgical treatments for trigeminal neuralgia, and gamma knife radiosurgery. Her lab focuses on the structural MRI techniques, and they're used to pinpoint key neuroanatomical signatures in different pain syndromes, and the use of imaging and surgical diagnosis and treatment. She also has a very interesting interest in neurosurgical education to strengthen the capacity in low and middle income countries, and is a board member of the Foundation for International Education and Neurological Surgery. So it's my great pleasure to introduce Dr. Hodaie.
Thank you very much, everyone. It's a real pleasure to be up here to talk to you about some of the work that we do. I know some of the members in the audience, and it gives me great pleasure to see you again. So, as Lisa kindly introduced me to you, I'm a neurosurgeon, but I'm a functional neurosurgeon. So what does that actually mean? What you're generally used to is thinking of structural problems in the brain, such as brain tumors or strokes, as Dr. Krings described. But for a lot of patients, what we have is this, a perfectly normal MRI, but we know that there's a disorder of function. So we treat a lot of these patients, and we want to know what we can do to understand what is happening in their brain better. As we understand that, we hope that we'll be able to treat them better. So what is it that I mean? One of the main things that I want to talk to you about today is the treatment of pain. So pain is a shared human experience. We don't understand that very well, short of knowing that we all go through it one way or another in life. And if we see an X-ray such as this, well, it doesn't look very good. We will presume that this person might be in some pain, but there's really no proper way that we can measure that pain, and we don't have any direct tests for it, short of asking the patient, how much pain do you have, and getting information that way. And we want to change that. One of the ways in which we want to change that is using imaging. And this captures an information that we all sort of know. So if you drop a ball of ink onto Kleenex, you see how it flows in every direction sort of equally. But if we do the same thing on newspaper, it flows primarily in the direction of the fibers. So if water does the same within nerve cells and nerve conduits, then we're able to capture that information as well. And this way we're able to, in fact, image these nerves. And this is a special technique called diffusion tensor imaging. Just remember the name DTI. And this is what it does. It takes the information of how water flows through these fibers in the brain and makes that into information of every specific spot, and with that we're able to reconstruct the fibers. So what I will be showing you from this point forward is all work that has been done in this hospital, in my lab, and if it's not, I will tell you. So all the pictures that you'll see will show you what kind of imaging we can have. So for at this point what we have is really imaging of brains that are sliced, which is great. Obviously we see quite a lot or brains that are dissected, or really fancy microscopes, and all of these are wonderful. But what we want to do is actually image the fibers of the brain. And the difference between this and the 3 other pictures that I showed you is that this person is alive. These are images that we've obtained from this person's MRI and not through a specimen. And using that, we're able to construct pictures that actually show us what the fibers of the brain are like, where they are, and the colors also represent the direction of those fibers. So there's a lot of information that we can get through this. And this has quite a lot of applications in neurosurgery. So you see to your left panel with the video, the structure in green is a large brain tumor, and we want to capture the image of those tiny nerves that are surrounding this tumor and are stretched, and they're not very happy. And if we operate on patients and we don't leave those intact, then the patient will have problems, including a completely limp face that cannot move. And there's other structures that are very fine, but we want to capture the detail from them, and then we can do that with this technique. Or take a full brain and just focus on these 2 tiny dots, ignore everything else, and look at those fibers alone, and this way study them. So with the millions and millions of fibers that we all have in the brain, imagine just capturing these small bundle and only being able to study those. That gives us a lot of information. So in this context, I want to tell you about this syndrome of trigeminal neuralgia. It's a severe facial pain syndrome. It's thought that there's a blood vessel, we generally see that is pushing on the trigeminal nerve, and the irritation of this nerve results in pain. So this is a great source of distress to patients. The pain is extremely severe, it's electrical, and generally very little stimuli such as touching the face or even wind blowing on your face can set off this pain. So it's quite upsetting. So we operate on these patients. And what we see is that the yellow structure is the nerves, that there's this blood vessel that is pushing on it, in some patients more, in some patients less. And the goal of the operation is to move this blood vessel out of the way. I'm going to show you a small portion of that operation. This is our view through the microscope as we do the microvascular decompression. The yellow, the white sponge that you see measures 1 centimeter across. So it's fairly small. Can you start the video for me? And you will see that white structure at the depth is the nerve. There's pulsations because the heart's beating. And this structure over here is a different nerve. It's the nerve that helps us hear and helps our face move. So we have to be very careful of it. And you'll see that there's a blood vessel now that we just pulled it out. That was stretching the nerve really thin. It's now out. The nerve is free. The vessel is free. And we will be putting a piece of sponge there so that there is less contact between these two. And very soon, both of them, still living in the same space, live and do so freely without bothering each other, which is what we want. So there's a number of things that we can do to patients that have trigeminal neuralgia. What I just showed you, microvascular decompression, or gamma knife radiosurgery, which doesn't enter the brain through the standard operation, but it enters through a beam of radiation just onto the nerve and tells the nerve to just settle down. So these are obviously important, but it's also important for us to understand how these work. So what we've developed is actually methods to see the nerves in great detail. You'll see here at the top, we see the trigeminal nerves, and we can carry them quite nicely. And with this new technique, we can actually see them inside the area of the brainstem, where we could not before. And again, all these colors represent a direction, so we know what fibers we're looking at, and then we're able to study them as well. But we want to isolate the fibers of the trigeminal nerve and only study those. Those are the ones we're interested in. And then we can capture, this is a busy slide, but we can capture this information and then compare nerves that are in pain with those that are not, people that are in pain with people that are not, and in this way do research to see what actually happens and why do patients have this unusual and very, very severe syndrome. You know of a disorder called multiple sclerosis. Patients that have multiple sclerosis also get trigeminal neuralgia, but in those patients, the problem is not the blood vessel. The problem in multiple sclerosis is plaques or really scars in certain parts of the brain that affects their function. And this is a patient with multiple sclerosis, and you can see this dark area over here, a little bit over here, and these are plaques. And if the plaque happens to fall close to the area of the trigeminal nerve, then they can have the pain, but not always. We need to study that again. So what we found is that in fact is a tiny, tiny change in the fibers just right next to the plaque that causes the pain in these patients. So for the first time, this study has shown how an imaging tool such as DTI can pinpoint the same pain in two different disorders and distinguish them. So this is a huge value that allows us to study pain using imaging. And when we study these in more detail, when we look at all the plaques, and this is many patients with their imaging stacked on top of each other, look, they have a lot of plaques, and the plaques are in both sides of the brain. That was not expected for us when we found it. Even though their pain is overwhelmingly unilateral, they have plaques in both sides. And here we have these fibers superimposed, again, so that we can study these in great detail and look at what changes occur in the brain and what changes occur in the nerve and link these with pain. And this technique, again, shows us changes in myelin, which is the substance that coats the nerves and gets damaged in multiple sclerosis. And in this way, correlate the pain with their disease and what myelin changes they have as well. So how does up to now I've talked to you about the nerve. How does the brain change in trigeminal neuralgia? Well, we can think of the brain as having two main parts, the cortex, or the gray matter, and the white matter. And we can compare that to something like an orange. We have the skin. Underneath the skin, we have this white area. We can think of that as a cortex. In the brain, that's where all the cells are. That's where all the major decisions get made. And then we have all of the stuff in the middle, which are the fibers that connect all of these areas. So we can study all of these independently. And I'll tell you how we do that. We have to, in fact, take the brain and keep only the brain. Everything that lines it and so on gets removed. And this way we are able to study the fine details of the brain. And this is one of the things that we can do. We take the brain and break it into tiny, tiny, tiny triangles. We remember all the details of those triangles, where they are in the brain. Are they over a hump or are they deep in a valley? And in this way, we're able to compare across groups to see what the changes are in pain. Just to show you what this is like, I wonder if any of you are familiar with the works of this artist. She's a New York-based artist by the name of Kumi Yamashita. It's a very beautiful piece of art. Do you know how she's done this? These are all nails, and she has run a single uninterrupted stitch through all of these to come up with that picture at the end. So imagine if from all of these we could remember where the nails are, what the thread is going through, what are the sizes of those triangles. So that's the kind of information that we need for each of these brains so that we're able to gather the information on what happens to the gray matter, to the cortex of the brain. And then we're able to generate these pictures that tells us what the brain is like in pain. And importantly, we see, even though we see important changes in areas that actually help us modulate pain and help us perceive pain, we also see that when the pain is gone, when they have had successful treatment and they don't have pain any longer, some of these areas go back to normal. So the brain is very adaptable, and when the pain goes away, is able to gain back its original structure. So this tells us how the brain processes pain and what are the events that are happening. So one of the important questions we want to know as well is, can brain imaging help us predict whether treatment will be effective? So this is of great value to us. When we see a patient that has not had treatment before, we want to have an idea of what it is that we're able to offer them, how likely is it that they'll be better. For our patients that have Gamma knife, for example, if they're doing good after treatment, that's wonderful. But there's a subset of patients that are a little bit better, not quite sure. Some of the pain has come back. They're not entirely pain-free. For those patients, really up to now, all we've been able to do is just follow them in clinic and see how they're doing. But now we are able to, using this technique, have some understanding of what likelihood is it, or do they have for their pain to be away for a long time. And we see that the footprint that radiation leaves in these patients is actually quite significant in patients that respond, whereas patients that don't have the same response, then their footprint is essentially absent. So we're able to treat these patients quite a lot faster because now we have an objective metric, an objective measure to follow them with. And this is going to help us a lot in clinic because instead of just following them at 6 months, following them at 1 year, following them at 1.5 years, we're able to introduce this specific measure on an MRI and based on that decide whether they need the treatment faster or not. You've heard about the field of artificial intelligence and machine learning. Well, the most complicated machine is the brain, so surely we are able to use those techniques for this as well. So in this field, one of the key things is you teach a machine to distinguish patterns, and you train them with a set of data, and then you give them some data and tell them, can you distinguish one pattern versus another? So the data that we gave our machine to distinguish is pain, and what we want to know is, are the changes in the brain specific enough that are able to be distinguished when we do this technique? And in fact, they are. This is a little bit complicated. We use a lot of MRI data, and afterwards what we find is, in fact, that the brain that is in pain is very different from one that is not. And there are key areas that are different, not just all over. So these key areas are very important for us because they will help us find new targets and new methods of to treat our patients. So one of the examples that I use for the brain and to understand how the brain works is you can look at a highway such as this. We can go and study the roads and figure out, well, this is a pretty big highway, so I'm sure a lot of cars must go through here. And if it's a small road, then likely you will have less cars. Or you can study emissions, and if there's a lot of emissions, then likely a lot of cars have gone by. Or you can look at what the speed of the cars is and which lane they are, and that tells you of the very fast connections that areas of the brain have with each other. So we have a machine in this hospital called a magnetoencephalography machine, which is a MEG, very long word. And this helps us understand these very fast connections that the brain has and how these different areas of the brain talk to each other. So it measures in different waves, and you can think of those as the different lanes on the highway. You have the slow lane, you have the middle lane, you have the fast lane, and a number of them. So if we look at a normal brain, this is how we look at them. These are the different waveforms that we look at. These are a lot of neuroanatomical areas, tiny, tiny names written down. And the colors, each of these colors corresponds to a different part of the brain. And we see how the different wave patterns tells us how these parts of the brain are connected with each other. This is one of our healthy controls that sat in the machine for a while for us. This is a patient with trigeminal neuralgia. Very different pattern. So we see very clear changes in these patients when they are in pain. This machine is used frequently to look at things such as seizures and epilepsy. This is really one of the first instances in which it has been looked at in patients that have trigeminal neuralgia. So what is the future of our work? Well, for years and years, for as far as I can remember, we've relied on clinical data. So people publish studies of the number of patients they've looked after, how well they've done with different procedures, and the experiences in one country or one research group versus another. This type of imaging is really a new way of looking at this disease, and in my view, has completely revolutionized how we understand pain in trigeminal neuralgia and what we can do about it. And what is important is that we're able to look at every person individually. So that gets us closer to what we want is precision medicine, so that we don't have a whole bunch of people's data to share with you, but your own, and we're able to focus on what is the best treatment for that patient. You remember this, black and white TV? I remember it. I remember our TV when I was a kid. And then this came along and took over, and none of us really want to go back once we see this burst of colors. So it's the same thing for us. We started really with a gray-white MRI, and now we've changed that to looking at great detail in color with information that we derive from those colors, looking at different parts of the brain, the nerve, the cortex, the white matter, and really gaining information in that way. And we're able to carry that study now, obviously, to look at how we can improve this method of imaging, how can we make it more detailed, looking at a number of fibers on one map. So these are 10 people sort of superimposed on each other, and what they have in common and what are the differences. And really going from pictures that we see in textbooks and drawings to what we can see in a normal individual and person with disease, and how that speaks to what that person needs. At the end of the day, the impact of this work obviously is clinical as well as research. The benefits extend well beyond what I do in terms of pain and functional neurosurgery. I have just shown you what we've done with one disease. Imagine if we had this for all our work in tumors, spine, stroke, vascular problems of the brain. It would be an amazing thing to do, and of course for that we would need an infrastructure and support. So the support of the foundation has been incredible in this area. Above all, what is of value is really what our patients tell us. So this patient to the left had had his pain for 12 years. He was actually referred from a different neurosurgical center in Ottawa to see whether we could help him. My patient up here is well in his 80s, and he was in terrible, terrible pain, and all he wanted is to be by his lake in Temagami. And I'm very happy that he was able to achieve that I was able to give him that freedom from pain. And the family is expressing their gratitude with the treatment of their son, who was in terrible pain because of trigeminal neuralgia. So, obviously, this work is done not just by me. I have a huge team in my lab, dedicated students who are championing this as their goal for studies and careers. And I'm so excited to be able to share this with you today. And thank you very much again. And I think you'll be introducing our next speaker. Shall I go ahead? So, again, it gives me great pleasure today to have one of my patients, to be here to speak with you, Maureen Shaughnessy-Kitts. And I think this is a wonderful opportunity for us to appreciate what impact this has on patients directly. Maureen.
Thank you, Dr. Moji. And thank you so much for the opportunity to share with you my recent, really unexpected time as a patient here at University Health Network's Toronto Western Hospital. I have been a grateful patient of the UHN system for many years at all 3 campuses, Toronto General, the Princess Margaret, and here at the Toronto Western. A number of years ago, Dr. Charles Tatter, this institution's world-renowned neurosurgeon, diagnosed my acoustic neuroma, a benign tumor located on the cranial nerve that runs from the brain to the inner ear, controlling hearing and balance. The treatment I chose under Dr. Tatter's guidance was gamma knife radiosurgery to control and hopefully shrink the growth of the tumor. Patients like myself, undergoing a number of different medical challenges within their brain, are so fortunate to have the benefit of the Gamma Knife program here at Toronto Western. Gamma Knife radiosurgery is made up of focused beams of radiation that deliver single doses of therapy with a precision of less than 1 millimeter for areas of the brain where traditional surgery would be too difficult or too dangerous to undertake. Being non-invasive, patients return home the same day as their treatment and generally return to their normal schedule within a day or two. Now fast forward to about a year and a half ago. I suddenly started to experience an unusual and aggressive pain on the right side of my face. I originally thought it might have emanated from a root canal, yet that proved unfounded. Traditionally, over-the-counter medication did absolutely nothing to ease the pain. Over a period of months, I was finally diagnosed with trigeminal neuralgia, this inflammation of the trigeminal nerve causing intense, and in my case, relentless facial pain. Something as simple as brushing my teeth could trigger an excruciating, severe attack. With the diagnosis, I reached out to Toronto Western's neurosurgeon, Dr. Hodaie, who more recently has been following my acoustic neuroma. She in turn referred me to her colleague, the talented and caring Dr. Moji, who you just heard from. You have no idea how meaningful it was to finally meet with someone who understood what I was experiencing. In my case, it was an atypical trigeminal neuralgia, as I endured constant, extremely intense pain, even while taking high doses of medication specific to its symptoms. Given my case, and after explaining the why of what I was experiencing, Dr. Moji recommended neurosurgery. I felt such relief knowing that while I was living with intense pain, there was a hopeful solution. Surgery was scheduled, and from that moment on, I felt I was in the hands of an extraordinary, multidisciplinary team. In the days and weeks that followed, from Dr. Moji's assistant Kiki to MRI technicians, to the admitting staff, to emergency and surgical teams, to post-op and patient support teams, and so many other kind, caring professionals, I was instilled with a confidence and an absolute trust in each step I was to undertake to reverse my condition. You know, we hear about the strain on the medical system here in Ontario, which is true. That hospitals are stretched and understaffed, likely true. Yet I can reassure you that as a patient here at Toronto Western Hospital, I never experienced anything but world-class individualized treatment throughout my entire journey. I had the kindest anesthesiologist who, like Dr. Moji, by noon on my operation day was likely completed a number of operations, yet I'll never forget, she took such time chatting with myself and my sister Honora, explaining what I was about to experience with my surgery and how she would care for me. To this day, I remember those kind words in her face as I woke up from the operation. And I will never forget Dr. Moji on her visit following the operation, explaining to me in the most simplistic, professional way that the culprit, which she had suspected, was indeed that acoustic neuroma I mentioned a few minutes ago. It was scar tissue from the acoustic that was lodged against that vessel on the trigeminal nerve, causing the relentless pain. Now, like with everyone with a Type A personality, you are absolutely convinced you will be back on your feet in hours or days following your neurosurgery. Well, much to my surprise, I was totally taken aback about how weak I was, which of course lasted longer than I'd like to admit. It was during those moments, that I realized how blessed I was to have the care I had and would continue to receive at this amazing place. My recovery was not without setbacks, which for a period longer than we expected, yet here I am today, totally pain-free, trying hard to share with you what it was really like living with trigeminal neuralgia. Thanks to this extraordinary care I received at the Toronto Western. As a grateful patient, know that I am just one of hundreds of patients each day, thousands each year, that walk through the doors of this hospital. I also know that the professionalism they experience and the care that they are afforded in a time of their particular need is second to none. Dear Dr. Moji, to your team, and to all who were part of the multidisciplinary team at the Toronto Western that cared for me, I can't thank you enough for the kind, loving, world-class, exceptional care I received during such a difficult time in my life. And most importantly, to each of you, your ongoing commitment and support of UHN and here at the Toronto Western is the greatest of gifts, a gift that has and continues to touch so many good people who are treated at this great institution. Thank you for your kindness.
Thank you, Maureen, for sharing your story. That was absolutely wonderful. And thank you, Dr. Hodaie. If I could invite Dr. Krings and Dr. Hodaie up to the podium. We have a few minutes for some questions from the audience. And we have some microphones here, so if you could just raise your hand and we'll bring a microphone to you. Also, if we can't answer all the questions, which usually we run over with questions, hopefully our doctors will stay afterwards that you can ask them yourselves personally as well. So if you could please come up. Thanks.
I hope this is related, but I'd like to learn more about the aneurysms. That's connected. I know my dad died of an aneurysm to the brain. He was 80. He also had aneurysms in his stomach when he was, I don't know, maybe he was late 60s, 70s, but it eventually, they couldn't save him. But could you explain that to me? Yes.
So that's a very wide field on aneurysms, but just very briefly, an aneurysm is a focal weakening of the blood vessel wall. And it's, if you think about the blood vessel, has normally a muscular layer so that the arterial pressure that we have can be withheld within the artery. Now, if this muscular layer is for reasons that we are investigating and that are presumed to be related to some form of inflammation within the wall weakened, then a focal outpouching may start to grow. And then according to simple physics, i.e. Laplace law, the bigger the outpouching, the thinner the wall. At one point in time, this wall may rupture and then lead to a catastrophic bleeding in the brain. Approximately 1/3 of the patients who have a subarachnoid or this type of bleeding in the brain die on the spot. 1/3 of patients die despite medical care, and only 1/3 of the patients approximately actually survive this disease. So it is a very bad disease, which is why we are thinking that we should treat maybe those patients who are at a high risk of having a bleed, because the aneurysms may remain silent, but we can identify them on imaging. And if we see this, we are, in certain cases, we are trying to do individualized medicine. We can say that this aneurysm is at a higher risk for bleeding, therefore we do a prophylactic type of treatment.
Hi, my name is Elaine Chellin. I'm a grateful patient at this hospital. I owe my life to Dr. Karl Jabrug. I had well, I still have an AV malformation, but he's had it under control. What I want to ask is, with all of this intervention, is there anything that is coming up that you can find to prevent these strokes and these kinds of things? Because until you have it, you don't know it's there, and then it can be too late. But what can be done to find it earlier, because they seem to be silent? And I have a second question, which isn't related to medicine, sort of. What percentage of your funding comes from donations for your research, and what percentage comes from the government?
Regarding to your first question, indeed, vascular malformations are silent until they become symptomatic. Now, therefore, one can think of maybe we should all go into an MRI and have a scan. That would be definitely not so good for our healthcare system. And this is why we need health services research. How much money are we willing to spend for this type of service? Is it really necessary? In my personal opinion, it is difficult, if not impossible, to scan every single person. I think that we'll have to think more about certain diseases that are genetic, i.e. where there's a certain component or people that are at higher risk of having these types of vascular malformations or aneurysms. They need to be screened, that's for sure. But screening the entire population is presumably not something that we can do. It could change if we get machines that are faster in imaging, and if we change the healthcare system in this regard, but this is not yet at the horizon. What we are working on with is also thinking about what is happening before a vascular malformation actually occurs, because we are not born with most of these vascular malformations. We are born presumably only with a propensity to develop a vascular malformation. And this is part of the research that we are doing. Our colleague, Dr. Ivan Radovanovic, in neurosurgery, for example, has identified that a certain gene is mutated in patients with brain AVMs, and this would open the potential of, at one point in time, a diagnosis that can be done via drawing blood. So I think we are not there yet, but we are working on it. Regarding your second question, I think it varies from individual doctor to individual doctor. In my personal case, I do have 2 grants, one from the National Institute of Health in the United States and one from the Canadian CIHR. That are giving me a significant research dollars, so it's approximately 50-50, my personal.
If I can address that, that's a fantastic question that you asked about granting. Obviously, a lot of research projects require us to be in touch with our colleagues, and that also invites the possibility for applying for grants. One of the key contributions, in my view, in terms of the foundation and people that want to contribute to this type of research, is helping us establish an infrastructure so that we can expand what we do in areas that are not yet quite ready, but we know that they apply to other fields. So in my own particular research, for example, as I said, I showed you what we do for pain, but we can apply this to many, many other areas. So that's not quite ripe yet for it to be funded by a government granting agency, for example. But it's a service that we provide to our division, our community, and of course our patients. So those are very key areas that the foundation, the support of donors is instrumental for.
First of all, thank you for your services and your fascinating presentations, although some of the information is a little formidable. I'd like to ask more questions about the management of the cost of research. For example, is research ongoing if funds are lacking? And secondly, is there an international sharing of research?
So your first question was, is research ongoing and are funds lacking? So research is ongoing and we can always use more funds. I have way more ideas than I have money for those ideas. So that's always a bottleneck. obviously, we have students, these are graduate students, PhD students, postdoctoral fellows, research analysts, and so on that work with us. So each of them, in my lab at least, is designated at least one project. So that if we have an amazing discovery that generates 5 projects and we don't have people for them, then we have to wait until funding becomes available. So that is always a bottleneck. And your second question was whether we have international collaborations and so on. Absolutely. It's something that we very much hold dear, to share ideas with other people. And in fact, UHN and the Toronto Western Hospital, particularly in the field of neurosciences and neurosurgery, is world-renowned. And therefore, we have a lot of people that want to come to us to learn our techniques and share ideas. They have their own projects in mind and want to know whether they can use some of our techniques. And we go to a lot of conferences as well to share our discoveries. So international collaboration and sharing of research ideas is essentially a must if anyone's involved in research.
I fully agree, like especially in the field on interventional neuroradiology, we have significant connections to various centers across the world, including mainly China, Europe, multiple places in South Korea. The research that we are liking to do with these types of institutions is that we are sharing databases. For example, my predecessor, Dr. Bruges, has the world's largest AVM database. And with this database, we can combine it with the databases, for example, from Tiantan Hospital in Beijing, or with the South Korean group, or with the other types of research fields, and therefore work and have more validity to our data, especially when it comes to retrospective studies.
Oh, hi. I'm hearing more and more from studies and doctors that they are recommending Tai Chi for mental and physical health. I don't know what you can say about Tai Chi. Okay, that's one thing. And then on the radio I heard this morning, and it happened to be today, to maintain your mental health, volunteering is good for being compassionate and for your mental health. So those are the 2 issues that I just heard, that I hear about. So I don't know what you can say about volunteering and Tai Chi.
I think we'll have to leave this for the next behind the scenes to get like a specialist in Tai Chi. I'm unfortunately not like a specialist in this field, but what is true is for sure the second point, like the volunteering part. I mean, mental health is of importance for our physical health, and mental health gets a boost, and it is known from the gratifying volunteer work, and it's something that is definitely recommended. I think we underestimate the link between mental and physical health.
Actually, I'll make a comment on Tai Chi. Well, maybe not specifically on Tai Chi, but you know the studies that I showed you that look at the cortex of the brain, the gray matter of the brain. There's many studies actually now published on the effect of meditation and what that does to the brain, and it does very, very interesting things. So our brain, there's no doubt, is a most interesting organ. And what I generally say is that it's the only organ that actually tries to understand itself. And in this light, it's also extremely adaptable. And what is a better method of adaptation than thinking of others? So in Tai Chi, obviously, it's meditation and focus and so on, and volunteering is thinking of others. And there's no doubt that that brings benefits to our lives.
Okay, we're going to, unfortunately, we are out of time, so hopefully they will stay around that we can answer some more questions for you personally here. And I just really wanted to take the time today. I don't know how do I get to the system. Okay. I really wanted to take the time today to thank everyone, to thank Maureen for sharing her story, Dr. Krings and Dr. Hodaie. And I think it was interesting, the conversation and the questions that came up around philanthropy, because I think all of you know, as being loyal and generous supporters here, the importance of philanthropy in the work. And having these two superstars here with us at Toronto Western wouldn't happen without philanthropy, and the work and the research and the discoveries that happen is truly because of all of us that support the amazing brains and work that do go on here. So thank you all for all that you do for us and for all of you. It's giving back to all of you. So I hope you will join us in the fall. We are looking to have our next session in November, and hopefully it will be about stem cell research. So stay tuned, and we will make sure that we communicate this with you in the future. So thank you all for coming, and have a great afternoon.